Thank you, Jim, and good morning, everybody. I'm happy to see so many familiar faces, but I'm even more happy to see so many unfamiliar faces. I want to see new people here so that I'll know there are more people who can learn and know about this group of conditions. And this is, and the lectures that follow are intended to be educational sessions. And so I want to preface what I have to say by emphasizing you're such a motley group that is a varied group. Some of you are very medically sophisticated and know a great deal and have some educational background in scientific and biologic sciences. Others of you are medically and scientifically very naive. Not to say it in condemnation of you because you're not knowledgeable in this area, but the point is you're not all equally well equipped to understand technicalities or some of the medical things. Now, education is a repetitive process. If you remember when we learned the basics in grade school, we had to learn things by saying them over and over again. Many of the things I will say, you will hear again, perhaps couched a little differently by those lecturers who follow. But the point is, it'll all help you to see them from different perspectives and to learn more. And you'll also have a long question and answer period at the end of all the lectures, and then we can clarify anything that's in doubt. All right, that being said, I would say one more thing. I like this kind of a lecturing assignment because it's not like lecturing at a medical, formal, scientific meeting where everything you say has to be backed up by a citation, something in the literature that's been proven by randomization and by double-blinded study, etc. And everything is supposed to be objective with no personal opinions unless you can prove it scientifically. I don't have to do that here, nor do I have to disclose who I've worked for so as to give you a chance to think that I'm biased because I'm pushing one drug company or another. I'm here to express my opinion. You have to trust me enough to know that even if I push one particular drug or company, it's because I think it's in your best interest. I am only human though, and maybe I'm not 100% right in some of those judgments, but the point is it's all for your well-being and not for my own personal benefit. So with all that being said, let us launch into this, the proceedings. This entire group of neuroendocrine tumors is comprised by basically two general categories. One are what we've known originally as carcinoids, and the other are what has been known as islet cell or pancreatic neuroendocrine tumors. These two large groups comprise the neuroendocrine tumor groups in general. And for those who may not realize why this term neuroendocrine has been assigned to these tumors, it's because the cells that comprise these tumors have components that are partially those like cells of the neurologic system, the nerve cells, and partially like those of the endocrine gland system, cells that make hormones or substances that produce some response and are normal and natural things in the body. But both nerve cells and endocrine cells serve the function of transmitting messages, signals to get things done. The nerve cells carry impulses, carry a signal that goes down to some receptor that ends up causing a response. Whether it be a mental response or whether it be a physical response, it's a response to a signal that's transmitted basically over this wireless or wire system. whereas the endocrine cells release a hormone or a chemical that gets off into your blood, but also floats in the fluids that bathe the cells of the body and triggers off a reaction in a target cell or several target cells. For example, the thyroid hormones that regulate the metabolism rate of your body, they will be released from the thyroid gland, so on. Well, neuroendocrine cells, which are dispersed diffusely, not all lumped in one organ like the thyroid or the ovary or other organs, but rather scattered, sprinkled around in different parts of your body. These cells have the ability to release products that would be similar to the cells from which they originated. And as it happens, the neuroendocrine cells have the potential to make a whole host of different substances. That's why we have so many different types of neuroendocrine tumors, and we'll mention that in particular. But of all of the neuroendocrine tumors, the carcinoid is the common one. It constitutes 3/4 of all the neuroendocrine cells. And the others, the islet cells or pancreatic neuroendocrine tumors, PNETs, they comprise about 1/4. And for this reason, they're much rarer than the carcinoids. So, and sometimes terminology varies, and some people call carcinoids neuroendocrine tumors of the intestine, accepting that's not really a good application because they can arise elsewhere too. At any rate, on this first slide, you can see the listing of the different tumors. The carcinoid makes predominantly serotonin, but also other substances, tachykinins, bradykinin, and other things. These terms are not quite so important to you. When there's an excessive production of these substances, we get what's called carcinoid syndrome. In other words, a group of symptoms that are accounted for or caused by the excess of these products that are released by carcinoid tumors. Now, those tumors that arise in the pancreas mainly, although a few can arise elsewhere, are named after the product that they make. For example, insulin is a product from certain pancreatic cells, so those tumors are called insulinomas. And people suffering from these tumors will have symptoms like a diabetic who took an overdose of insulin. In other words, hypoglycemia. Vipoma is the name given to tumors that make VIP, long complicated name, vasoactive intestinal polypeptide. So it's abbreviated VIP, and it causes a profound watery diarrhea called pancreatic cholera, or Werner-Morrison syndrome, after the people who first described this, and so on. I won't go into each one, but you see the names glucagonoma, because it makes glucagon. Somatostatinoma actually makes somatostatin. And growth-releasing factor tumors, GRF-omas, make release its growth hormones and can cause acromegaly. And gastrinomas, which are well known, release gastrin and cause severe ulcer disease and also can cause diarrhea. So with that being said, we have an introduction. We'll talk in this presentation a bit about the PNETs, but mainly about carcinoids. And I might add that in many aspects they overlap. Some of the treatment is the same, but some is quite different depending upon the type of hormones being released. Now, here again, we're dealing with, in this slide, with carcinoids. And it shows you that the majority of carcinoids are released and produced from the digestive tract, usually the small intestine, but can be other parts, but predominantly the small bowel. And a smaller percentage, but significant, come from the lung. 28% of these carcinoids come from the lung. And a small number, 8%, come from a wide variety of other locations. They are very rare, like the kidney, the ovaries, etc. These are very uncommon, but very important because unlike those that have spread to the liver, when you have a hormone-producing tumor, a carcinoid of the ovaries, say, it drains its products directly into the venous system that bypasses the liver, the caval system, and hence can cause carcinoid syndrome without having liver metastases. And if you have such a tumor, then you can have a complete cure if it can be found and removed. Whereas in most of the cases of the intestinal carcinoid, there has to be metastases which already make it unlikely for complete cure. At any rate, you see listed here, especially I would like to comment about stomach. Gastric carcinoids are unique because there are 3 different varieties, and very important to know which kind it is. They have a considerable difference in their outlook. The commonest one, comprising over 60% of the cases, is called type 1 gastric carcinoid and is associated with atrophy, that is shriveling up of the lining of the stomach, atrophic gastritis. That usually occurs in patients who have pernicious anemia. It may not be recognized as pernicious anemia at the offset, but when we find stomach lining atrophy, we always look to see if there's pernicious anemia. Or sometimes with autoimmune diseases, so patients with gastric type 1 carcinoid may have Hashimoto's thyroiditis, a type of disease of the thyroid gland that may be the tip-off. At any rate, this group often is found accidentally, or maybe mild, vague symptoms of bloating or a little bit of indigestion, or just found at the course of gastroscopy for when we look into the stomach for other reasons. And you may see an absence of the normal rich lining of the stomach. In addition to that, there will be multiple little tiny nodules scattered about in the stomach. And this is because the cells, the endocrine cells that give rise to these tumors are overgrown. There's a hyperplasia of the endocrine cells in the stomach because there's no acid produced by the absence of the lining of the stomach, and the absence of the acid does not cause any shutdown of another hormone that the body makes called gastrin that stimulates normal acid production, and the result is there is stimulation of overproduction of these cells. And our treatment is designed at reducing the gastrin, and I can go into that later, time permitting. The second type of gastric carcinoid is associated with gastrinomas, which cause what's called Zollinger-Ellison Syndrome, which is named after the people who first described it. And that's a syndrome in which, because of too much acid produced, the patients get very severe ulcers in the stomach, in the duodenum, and even further down in the intestine, and may get diarrhea too. It's a cause of chronic, severe, otherwise unfathomable diarrhea that comes because of the increased acid that inactivates the digestive enzymes, and so we get profound diarrhea. Sometimes that may be the only symptom, and so can be confused with carcinoid syndrome. And that's important because if we test for carcinoid syndrome by doing the chemical tests, it'll be negative, and then we'll think that there is no neuroendocrine tumor where it may really be a gastrinoma. At any rate, the gastrinoma can be associated with multiple little carcinoid tumors in the stomach, and they are a little bit more malignant than those of type 1. Type 1, after many years, about 5% can actually manifest as malignancies with some spread, whereas in the type 2, it's a little bit more common, but much more insidious and dangerous is type 3, so-called sporadic gastric carcinoid, which is usually just one, occasionally two, but most commonly just one tumor. Single tumor discovered in the stomach as a polypoid, a little lump, or sometimes a big lump. And the surface may be ulcerated. It may have been presenting as bleeding. That one is very aggressive, very dangerous. At least 50% of them will spread, and it has to be treated as if it's an ordinary cancer. In other words, aggressive, rapid surgery. And it is poorly responsive to many types of chemotherapy. We'll dilate on that further, time permitting. At any rate, let us go on. As far as the prevalence, now, in medicine we use two terms, incidence and prevalence. Prevalence means how many cases there are all over. And this is the prevalence of gastrointestinal cancers of all different types at any given time. How many people in the United States are living at this given time with these cancers? You can see cancers arising in the colon and the rectum. Ordinary adenocarcinoma is the commonest, with over 1,100,000 cases. But surprisingly, neuroendocrine tumors, carcinoid and PNETs, comprise 1/10 as many, a little bit over 100,000 such cases. That is not quite that rare. And part of this is because most of these tumors, the neuroendocrine tumors, are slower growing. But that doesn't mean they're benign. They're malignant. They just take a longer time to do their dirty work. The prevalence of neuroendocrine tumors is greater than that of gastric cancers and pancreatic, ordinary pancreatic cancer added together. So it's really not quite as rare as we thought, a little bit more common. It's still considered an orphan disease, and that's an important designation, because to be designated as an orphan disease, a condition has to have a prevalence of less than 200,000, and here it is less. And it's important for that designation because Congress has afforded certain advantages to orphan diseases. They get more accelerated consideration for research purposes, grants, and for attention to drugs being developed for their use. So it's not just a meaningless term, but has significant political implications. Now we come to incidence. Here you can see on the bottom the years 1980, 1990, 2000, and you notice that the frequency with which diagnoses of these conditions are reported has been steadily increasing with every decade, and particularly carcinoids of different locations. The lung, the intestine, and the rectum have been the ones that have in particular increased. Now, it's not because we're really having an epidemic of carcinoids. It's really because there's increased awareness and better diagnostic modalities. And this is very important because the more cases that are seen, the more doctors will think about them, the earlier the diagnosis may be made, and also from a practical viewpoint, the drug companies who do much of the sponsoring, as well as the NIH, National Institute of Health, who also sponsor research in this area, will be more interested when there are more cases for which they can devote their attention. And here, listing the extent of the disease at the first time it's diagnosed. And this is after reviewing many, many cases. You can see rectal carcinoids are usually just very localized. They haven't spread in most instances, and they're usually considered fairly benign because they can be cured by simply removal, because they may be just very small little bumps that are accidentally discovered in the course of a sigmoidoscopy or colonoscopy. More than 50% of them are found in that fashion. However, lung carcinoids, which arise in the bronchial tree in the lung, 49%, about half of them are localized, but all the rest have spread, either locally or even more distally at the time they're first diagnosed. And as you can see, the diagnosis of almost all these tumors is very delayed from the time the tumors appear to have started until they're actually diagnosed, maybe 5 to 7, or in some cases, some statistics, even 9 years. So by the time the diagnosis is made, very, very often they're metastases. And this is something we can work on, and we are trying to do so. And I'll talk more about that later. Now, carcinoids of the small intestine, the jejunum and the ileum, a little less than 1/3 are localized when they're first discovered. 41% have spread at least locally, lymph nodes adjacent to the intestine where the primary lesion is, and 30%, almost 1/3, have distant spread to the liver and to other locations. That's reprehensible, and we really have to work against this. But unfortunately, this is what pertains in the majority of cases. And we'll go into more details about diagnosis in a few minutes. Here's a cartoon graph of the natural course, the history of the characteristic intestinal carcinoid that goes on to cause carcinoid syndrome. That is the syndrome of excessive diarrhea and/or flushing and a few other symptoms because of the increased serotonin and other hormones released from the tumor. And on the bottom here you can see these are years. This is the slope is the progress of the disease, and you see listed here the status. So the primary tumor is there with very few symptoms, vague abdominal symptoms, for a decade often, and then unrecognized and undiagnosed, or at least the minimal symptoms, a little bit of abdominal discomfort may be passed off as irritable bowel or some other condition and not extensively investigated. And by that time, after a decade or so, metastases have occurred. And then more and more cells grow, more and more hormones are released. We begin to get this carcinoid syndrome with flushing and diarrhea. And eventually, the course accelerates and the patient succumbs to the disease. So by the time we see carcinoid syndrome features, the disease is quite advanced, quite progressed, and we usually can't cure it, at least at the present time, but we can palliate, we can improve, and I believe extend life considerably. So, but the thrust now is to make earlier diagnosis, and we do have some ways that look very promising for accomplishing that. Now, here is a picture of a piece of intestine that's been split open, and it shows you what the usual little early carcinoids are. You see a nodule here, a nodule there, a nodule here. These are little lumps, little polyps that arise in the lining of the intestine. They are often multiple, as in this case. In fact, more than 1/4 of the cases will have multiple lesions. So if you get a big one and it causes obstructive symptoms and the surgeon makes an operation to remove it, to take out that section of the intestine, as was done here, he has to look at the entire intestine in order to know that there isn't any other tumor present in the rest of the intestine. In addition, I has to look to see there's no other type of cancer, because in a high incidence, at least 25% of carcinoids of the intestine, there will be what's called metachronous cancer. That means concurrent cancer, colon cancer, for example. So you have two bad things going on at the same time, and they both may be treatable, though. Here is a slightly magnified cross-section of one of those little nodules, and the nodule is no bigger than about 1/4 of an inch in diameter, and here you see the lining of the intestine covering it, and the yellow center is the actual tumor, and this layer here is the muscular coat, the muscularis propria of the intestinal wall. And if you look closely, you can see little strands of tumor going through, penetrating through that muscular coat into the area beyond it. The lining of the outer surface of the intestine is called serosa, and it's going into the serosa and even growing outside the serosa. So the full thickness of this part of the intestine is involved by this tumor. Now, this is a very, very important consideration, because when the full thickness is involved, when the muscularis propria has been invaded, the likelihood of distant metastasis is very great, or if not present now, of developing at a later time from microscopic deposits elsewhere. So we always want the pathologist to report on exactly the depth of the tumor, or we want to have a sonogram done when a carcinoid is found, say in the rectum, in order to know how deep it goes, even when it's a little tiny one. It's not good enough just to say it's carcinoid. Now, what are the presenting features of midgut carcinoids? Midgut means from the jejunum on down through the ileum and the proximal, the nearby right half of the colon. Well, abdominal pain is the commonest. As I said before, many patients will just have little minor indigestion or little gas pains for many years, passed off as irritable bowel or something wrong that they ate, etc. But that's the commonest. And then the pains become more often or more severe, and they are actually due to many episodes of intestinal obstruction. And then finally a bad real obstruction occurs, and the patient may end up being studied and they find carcinoid, or they find a blockage, and operation is done, and then carcinoid is found and diagnosed with certainty. That's a common scenario, and I'm sure among you there are those who've had this type of scenario occur. The next often way these tumors are found are as incidental findings. Somebody gets a gallbladder attack and has their gallbladder operated, and coincidentally there's a carcinoid. Or it turns out the gallbladder may have had stones or maybe didn't, but it wasn't the cause of the symptoms. It was the carcinoid that had been undiagnosed. That's not an unusual scenario. Occasionally, the tumor may become ulcerated, the surface raw, and bleed. So bleeding without a clear-cut cause may be the presenting symptom. And then finally, somebody may feel a lump in their belly, or at the doctor's annual exam, he feels an enlarged mass somewhere. That may be already the metastatic disease that's palpable. And then finally, somebody may present, as often happens, with flushing. It's not clear. Why do I get flushed now? I went through menopause 20 years ago, but I'm getting these hot episodes, my face turns red, or maybe I have unexplained diarrhea that goes on, and all the usual tests have been negative. Carcinoid syndrome, that's what's going on. Now for lung carcinoids, how are they presented? A good number, at least half, are found as a coincidental finding on a routine chest x-ray. Shortness of breath, and they take an x-ray and there's a lesion, we call them often coin lesions because it looks like a nice little round coin somewhere in the lung. Or there's a lump at the root of the lungs, and this is found then. Or a routine chest x-ray before a surgery for some other procedure, whatever it may be, turns up a finding like this, which may be a lot more important than the surgery that was going to be done. So it's an incidental finding. Another way these tumors present is recurrent infection, because the bronchial tube is being blocked and the mucus can't get out that normally is produced, and so there's infections over and over again, always in the same section of the lung. So they have to look for why that's occurring. CT scan or some other type of study is necessary. If there's coughing up blood, blood-streaked sputum, hemoptysis, that's the fancy name for it, that may come from the tumor. Or if there's a chronic cough without producing any phlegm or bleeding, but it's just unexplained and it persists and persists, it may come from a carcinoid in the lung. Or just like the gut carcinoids, distant metastases may show up and may be the presenting feature. And then finally, we can have an endocrine syndrome, carcinoid syndrome, be the presenting feature due to the spread. However, lung carcinoids have the potential of making almost any hormone that the body can make, and in particular can make ACTH, which is the hormone that stimulates the adrenal to make cortisone, and so we get Cushing's syndrome, which normally occurs as a result of an ACTH-producing tumor in the pituitary, which then stimulates the adrenal gland to make too much cortisone. And that's Cushing's disease. But Cushing's syndrome is when an ectopic source, that is outside of the brain, is the origin of ACTH. And the lung, the carcinoid in the lung, is the commonest ectopic source for this in all of Cushing's syndrome cases. And so we have to suspect it. And the major features of Cushing's are obesity, weakness, red face, and hypertension. And somewhere these overlap carcinoid syndrome. So when carcinoid syndrome is suspected, but there's hypertension, and the patient doesn't have the chemistries of carcinoid syndrome, we have to think outside the box of unusual other syndromes. Okay, how is carcinoid diagnosed? Well, the first and most important thing of all is for the doctor to suspect it. If you don't suspect it, you can't detect it. There's no way you'll have the right tests done. This is, of course, a pointer that's more germane to the doctors to whom I might be lecturing than to the patients. But as informed consumers, you can remind your doctor of things like this. At any rate, suspicion then leads to the right workup. And among the things that can be done are to test the chemical markers, to measure the urine, measure the blood for the products that are associated with carcinoid tumors. They don't prove it, but they certainly give a strong indication. And then we can do imaging, scans or other types of pictures, which I'll show you representatives of. And then finally, we absolutely clinch the diagnosis by a biopsy. And the biopsy tells us not just what it is, but exactly what category it is. And that helps to tell us what the treatment should be. Now, the markers, which is the term we apply to the chemical substances. The classic one is urine 5-HIAA, abbreviation for 5-hydroxyindolacetic acid. It's the waste product of serotonin, and it's excreted in the urine. However, it's not 100% guaranteed to be accurate. In about 1/4 of the cases, the body doesn't follow the rules, and the result is that there's no increase in 5-HIAA. So if the doctor relies only on this, there's a good chance of missing the tumor. Blood serotonin can be measured. These are all commercially available in regular routine laboratories, and that is even in cases that don't have carcinoid syndrome, it is likely to be elevated a little bit, not as high as it would be in carcinoid syndrome, but above normal, and that's a tip-off that we are really dealing with a carcinoid. And of course, these substances can be measured sequentially to gather information as to response to treatment. If tumors are shrinking, then the markers are going down, and that's a very good help to tell what's happening, rather than to go for a monthly CAT scan, which is not feasible. Chromogranin A is another peptide or protein derivative which these tumors usually, but not invariably, produce. This is not specific just to carcinoid, but all neuroendocrine tumors, with 1 or 2 exceptions, such as insulinomas, which don't usually produce much except for insulin. But it's a non-specific marker that helps to confirm that we're dealing with a neuroendocrine tumor. But there are many, many other substances or physical conditions that can falsely elevate the chromogranin A. Just to give you a common example, if you take a proton pump inhibitor, so-called PPI drugs, these are like Nexium, Prevacid, Protonix, etc., that are used for decreasing stomach acid, they will cause a big elevation of chromogranin A, and the longer you take those drugs, the higher the chromogranin A will go, and coincidentally also gastrin may increase. I won't go into the mechanism of it, but it's well understood how. So you can get a falsely elevated chromogranin A, and this is a common mistake. I've seen patients referred to me because their doctors couldn't find the carcinoid, and yet they had a high chromogranin A. And it's very easy to understand, because when I ask them, have you been taking Nexium or such a drug? Oh, sure, I've done it for 5 years. And that immediately helps to clarify what's going on. These are the big 3 common ones, but there are other markers. Before I talk about them, I want to get a little bit more technical on the metabolic pathway, the chemical steps involved in serotonin's production and degradation. Tryptophan, which is an amino acid that our bodies find essential, is underlying as the raw material from which serotonin is made. And you have to acquire it by eating it. you can't make it as you can make other amino acids. And the normal purpose of tryptophan is to form protein, muscle, and other things that are comprised of protein, and nicotinic acid. This is a vitamin that is essential, and the deficiency of it causes a disease called Pellagra, which starved people like prisoners of war in World War II would get. And Pellagra, in a patient with severe untreated carcinoid syndrome, where an excess of tryptophan is gobbled up, cannibalized to make serotonin, occurs, and so the other pathways that are served by tryptophan suffer, and nicotinic acid is one, and the patients may get Pellagra. And in a study I did many years ago of a large number of newly diagnosed carcinoid syndrome patients, we found that over 1/3, almost a half of them, had subclinical unrecognized Pellagra. Now, what are the features of Pellagra? Pellagra is the 3 Ds, diarrhea, and superimpose that on top of carcinoid diarrhea, and you really have a bad combo. Dementia, that means mental effect, forgetfulness, confusion, hallucinations, paranoia, etc. And dermatitis, the 3 Ds. And dermatitis is skin rash, particularly in the areas exposed to the sun. And these may be superimposed on top of untreated, unrecognized carcinoid. This is all corrected by taking niacin or nicotinic acid if you have carcinoid syndrome. And many of our foods are ordinarily enriched with such. But this is an important observation, especially if you don't eat well. At any rate, the next step in the synthesis of serotonin is the formation from tryptophan of hydroxytryptophan. And there's an enzyme called tryptophan hydroxylase, which is involved in doing that. And one of the reasons I'm showing you this chemical pathway is because there's a new drug just entering clinical trials that is hoped will control the diarrhea of carcinoid syndrome, which is felt to be due to serotonin, and maybe even have other benefits like reducing the occurrence of heart valve lesions in carcinoid syndrome, which occur as a result of the effects of high and chronic exposure of the heart valves to serotonin. And this new drug is a drug that inhibits this enzyme, tryptophan hydroxylase, the enzyme that converts tryptophan into serotonin precursor, 5-HTP. And so the clinical trials of that drug are underway right now. The preliminary trials were very successful in accomplishing this. At any rate, in the neuroendocrine cell, the enterochromaffin cell, that's the origin of carcinoids, all of these reactions take place. At any rate, the 5-hydroxytryptophan is then converted to serotonin by another enzyme, and then serotonin begins to be inactivated through 2 steps. It's converted to an aldehyde, and then that to hydroxyindoleacetic acid that's excreted in the urine. But as I said before, about 25% of the cases will not excrete large amounts of 5-HIA because there are also other metabolic pathways that serotonin can follow. Other markers, these are much less commonly used, but sometimes important. They're not specific, pointing to saying this is just carcinoid, but may be present in any of the neuroendocrine tumors. Neuron-specific enolase, substance P, pancreatic polypeptide, pancreastatin, neurokinin A, and the alpha or beta subunits of human chorionic gonadotropin, which are increased in pregnancy, for example. I'll dilate for a minute on pancreastatin. Pancreastatin has risen to the fore as being very, very sensitive. It's not that specific for carcinoid, but it's good for all neuroendocrine tumors and predominantly carcinoid, and is, unlike chromogranin A, subject to variations by external things, by medicine, PPI, exercise, kidney failure, liver failure, etc., all of which affect chromogranin A levels, but pancreastatin isn't. So sometimes when I'm in doubt, I will do both pancreastatin and chromogranin A. And if they're both up, then I know it's for real. And if they're not both up, I may hesitate then. And here again, these are specific markers for the different PNETs. And I mentioned them before: gastrin, insulin, glucagon, etc. And each one can cause its own syndrome. We won't dwell on these. And I mentioned most of these features that can give spurious elevations of chromogranin A. Now, for some of the newer events, newly emerged diagnostic techniques that are still experimental, but yet are somewhat available. Molecular profiling of tumors, that's not so experimental. It's in use and has been for a number of years, and is gaining in popularity for neuroendocrine tumors in particular. And what this depends upon is taking the tissue, the sample that was obtained at the surgery or the biopsy, submitting it to very new genomic techniques, that is gene analysis methods, DNA analysis, and they go by different names: IHC, immunohistochemistry, staining the slides with chemicals that will, by their reaction and color, tell us what the chemicals are present. FISH, which is an abbreviation for fluorescent in situ hybridization. That's a mouthful, but it again is a gene studying technique. Microarray, another similar one, and then qPCR, which is real-time polymer chain reaction, a DNA gene analyzing technique that allows an astronomical number of substances or genes being analyzed at one time. These are all put together, and they're all dependent upon the development of the most sophisticated computerized machines that can analyze a specimen and tell us what the fingerprint, the chemical fingerprint of the tumor is. And by knowing that, we can now discern with a reasonable good accuracy what drugs that tumor may respond to. And this helps us in our choice. And I insist on it in all my patients because it's very expensive, but fortunately most insurances cover it. And this is very important. It had a bad name, that is molecular profiling, because it wasn't very effective for ordinary cancers. And many prominent institutions spoke against it for a good number of years. But it has become very helpful for carcinoids and neuroendocrine tumors, and is gaining in popularity now. And even its exponents in the past are weakening and using it sometimes. Using similar techniques, we can often find where a tumor arises. In other words, if you have metastases and you can't find the primary, and that is what occurs in about 10% of cases. We find liver tumors, but we don't know where it came from. And as you saw, it's important to know where the origin was to help you in predicting what's going to happen and also in deciding how to treat. We can find the identification of the origin by the molecular analysis of the metastases, and there's even a company, a commercial laboratory that's now established to do this type of analysis. And then finally, and most important, and you're going to hear more about this in a future meeting of this New Jersey group, since a representative of the laboratory that does this is going to be speaking to you. It's a group of testings in which they found a pattern established that they call a fingerprint, if you wish, for genes that are floating around in the blood that are released by neuroendocrine carcinoid tumors. And the pattern varies minusculely, but nonetheless discernibly, to these newer sophisticated and analytic techniques. And they can tell you very, very early if there is a carcinoid present before it's discernible by any other means. Furthermore, by measuring repeatedly, say, doing it before and after surgery, whether there's any microscopic deposits of tumor left, or because it's supposed to be that sensitive that it can pick up little bits before any other way can tell. This is now just beginning to be made available commercially, and it's still under study, and a group of centers are going to be carrying out such studies. My group is one, and I've reviewed all the original literature and its findings, and I'm very impressed with it. I think it's the wave of the future. Now, quickly, since I'm taking up all my time, I think, standard imaging techniques in the diagnosis, standard X-rays, CAT scans, MRIs, you've all heard of and know of from your own experience, sonography, ultrasound scans, isotope bone scans to see bone lesions. Octreoscan, however, has been the gold standard, the best way, fairly specific for carcinoid and other neuroendocrine tumors. It's these tumors have on their surface of the cells receptors, 5 different types, but one particular one, receptor 2, is avid like a magnet for certain substances, octreotide, for example, which is a manufactured derivative of the normal hormone called somatostatin, and these are called somatostatin receptors. At any rate, they take a derivative of somatostatin and they bond a radioactive isotope to it, indium-111, and that's given as an injection and floats around throughout your blood, and wherever there is one of these tumors that has an abundance of this right type of receptor, this material is attracted and concentrates, and then they do a scan for the radioactivity and it lights up and you see a hot spot and you know there's a tumor, and it helps tell you what kind of tumor it is too. I'll show you a representative picture. This has been very popular and it's been the best technique in the last 20 years, but in the future it will be replaced by another scan called gallium-68, and you'll hear more about that later today. It's even 10 times or more sensitive than the Octreoscan, and it's been in use in Europe for the past 10 years or so, where it's now almost always replacing Octreoscan. It's only available experimentally at present in the United States, but the way of the future is obvious. It's going to replace sandostatin, and even as an investigative procedure, will do so very soon. At least I feel convinced about it. Now, Fdg Pet Scan, that's the standard PET scan. When your doctor says you got to have a PET scan, Fdg means fluorodeoxyglucose, or in other words, it's a sugar which has got a radioactive isotope bound to it, and it's attached to a ligand, a substance which is drawn to tumors. Now, the ordinary cancers are faster in growth than ordinary body cells, and so they have a higher metabolic rate. They need more fuel, or in other words, sugar. So a cancer will attract this material because it's got a sugar core to it, and so it will light up on a scan. But carcinoids are slower growing, and they don't have a high metabolic rate, and so they don't usually show up on an Fdg PET scan. And if your doctor feels a lump and he thinks cancer and goes right to the PET scan, gets a negative PET scan, says, well, it's not, it's something else, he may be very wrong because of the slow rate of growth of carcinoid. I use a PET scan only to help me tell how rapid the carcinoid is growing. Is it aggressive or isn't it? But I don't always have to do that by going to the extreme of doing a PET scan. We now also can take the Octrio scan and combine it, fuse it electronically with the CT scan. So we not only see the hot spot, but we can indicate more clearly exactly where it is, and that's a help. Then finally there's an MIBG scan. I won't tell you the tongue twister that stands for, except that it's another type of scan using another substance that's particularly useful for the rare pheochromocytoma, or a similar type of adrenaline-producing tumors, but is not that good for carcinoids and other neuroendocrine tumors, only being positive in about 1/3 of the cases. Now, quickly, just some illustrations. Here you see two pictures of the body, a cross-section, the liver, and here are great lumps of tumor tissue in the liver. One is a CAT scan and one is an MRI, and here they are again, by showing, looking somewhat different, but nonetheless the same lesions in these two different modalities of imaging. And here is a sonogram, an EUS, endoscopic sonogram. That is, a device is inserted into the body, into a body cavity, and emits high-frequency sound waves that bounce back like radar and show echo of the lesions in there. And this is inside the rectum, and this is the lining here. And here you see a bump, and here magnified, you see this is a small tumor, a little carcinoid in the rectum. And each layer, it represents the mucosa, and the other layers deeper. And this one is just limited to the most superficial. So this can be easily cured by simply taking out, even endoscopically, with a little tiny device through the rectum, painlessly and in a quick visit. Fortunately, that's the way most of these little rectal carcinoids are. There are exceptions. And here's an Octrio scan. This is what we call a planar image. It's not a cross-section, but just an overall straight, flat view. The isotope is taken up by organs, and this gray organ is the liver here. I'm outlining it. And this is the spleen. This is one kidney. That's the other kidney. And these very dark black areas are foci of isotope in tumors. And you see quite a few of them in the liver. And one here, that may be the gallbladder, which has lots of the isotope being excreted in the dye. And down here, the urinary bladder, because the isotope is excreted in the urine. So this is an Octrio scan. And now here is an angiogram of the liver. A catheter has been put, and this is the hepatic artery, the main artery that gives blood to the liver. And the carcinoid tumors are very vascular. They have an increased number of little blood vessels compared with normal tissue or other tumors. So they get an extra blood flow, and you see them here outlined as small cannonballs. And this is the basis for hepatic artery chemoembo, bland embo injection, or radioisotope embolization, yttrium-90, that some in the audience have had done, because injecting the substances into the artery here, the injected material will be drawn, monopolized to the hypervascular structures, and so focus and the particles get caught and impinge into the small vessels in the tumor and give intense localized radiation. So this is SIRT, Specialized or Selective Internal Radiotherapy, SIRT, another name for the same thing. Now here, this is a stomach, and here is a lump. This is a carcinoid in the stomach. And I want you to notice the particularly smooth appearance of the rest of the lining. It's not rich and velvety. This is atrophic gastritis. That's a type 1 gastric carcinoid. Now, here is a picture taken with the wireless capsule, pill camera, that you swallow and can see things in your intestinal tract as it passes down. And and if it's under the lining, it appears like a lump, a bulge. So here is a bulge, and the lining is stretched, and it describes it. And it doesn't tell us what the bulge is, but we know there's something real there. There are some newer techniques that we can, the double balloon technique, and now a single balloon technique, where a catheter can be passed down and an actual biopsy can be taken of some of these lesions. Finally, very important, the minimum pathology data required. This is very important. In former days, because of their rarity, when a biopsy was done and a carcinoid was found, the pathologist was happy that he could at least diagnose this rare tumor, and he'd just report carcinoid, and maybe say well differentiated, meaning the cells are mature, they're not wildly growing, or say poorly differentiated, meaning very aggressive, poorly characterized tumor cells. That's not good enough now. We need to know what the source of the tissue being examined was, what the site is, and we need to know what grade this is, the tumor. They're grades 1, 2, and 3, which are dependent upon the rate of growth, and I'll go into that in one moment. The mitotic index, how many cells in the process of mitosis, what is the proliferation index as indicated by a count of percent of Ki67 staining cells, or MIB1, which is roughly the same. These are stains that show the cells undergoing division, and then the diagnosis. Now, the standard immunohistochemical staining is staining for chromogranin and synaptophysin. That proves what it is. And then we want to hear a report of the TNM staging. That is tumor, lymph node, and metastases. And they've got a code for that, whether it's 1, 2, 3, etc. And that's specific for carcinoid. This is the uniform way we want to have a report now. And anything less has to go back to the pathologist and ask him to provide the missing information. Ki67 is a good predictor of tumor recurrence after radical surgery. You have big surgery taking out tumor and lymph nodes. We want to know what the Ki-67 was, because the higher it is, the more risk there is for recurrent disease. The lower it is, the more likely there won't be recurrence, or at least it'll take a long time. And this is, I won't dwell on this, this is just a grading system depending upon, for PNETs and for carcinoids in the intestine, what the grade system is, what the average 5-year survival is for the different grades. And that's part of why the grading is so important, because it helps us to make a prognosis. And finally, the last thing I'll have to say, and be very brief now, will be the question of treatment. I've divided treatment into 3 types: supportive, surgical, and anti-proliferative. Supportive means everything from pain relief to standard anti-diarrheal drugs, Lomotil, Imodium, etc., deodorized tincture of opium drops, and so forth. Vitamin supplements, niacin supplements, all of which I inferred earlier, and pain medicine, and so forth. Electrolytes, if you're losing so much potassium in your diarrhea that you need extra, then we give extra potassium, so on. Diet to improve your nutrition, such. Surgery includes a wide variety of things, from removing the tumor itself to debulking, to just reduce the volume of tumor present, since they grow so slowly that it may take 5 or more years to get back to the site, to the status you were at the time of the debulking surgery. Because of this slow growth, we're more aggressive in our surgery for these tumors than we would be for ordinary cancers, where the tumors grow so much, and if you take out a lot of it, but you leave some, it won't make much difference. You'll still progress in just a matter of months. Whereas here, if you reduce the tumors by 50% in volume or more, then you prolong survival that much longer. And then there are other things that can be done. Stents and tubes put in to alleviate obstructive structures, and even vascular surgery, and even cardiac surgery replacing diseased valves, and so forth. And then finally, anti-proliferative surgery. That means things to destroy or shrivel up the tumors. And this can be anything from radiation, external beam radiation, only good in certain situations, to internal radiation. I mentioned CERT before. And now we have also, at least in Europe, we do have Prrt, Peptide Receptor Radiotherapy, the injection into your circulation of a radioisotope attached to a substance, such as, for example, lutetium-177, which is a favored agent for PRRT now, which goes through the whole body, gets drawn to tumors wherever they are, even though they may be inoperable. Yeah. Dr. Lou is he's going to talk more about this afterwards. And as I said in my introduction, this is an educational session, and repetition is a hallmark of education. And I'm not going into the details of it. I will leave that in his able hands. And similarly, I'm sure he will talk more about the gallium scan, too. One thing he may also comment on is the wait-and-see attitude is no longer acceptable. More aggressive surgery and more other types of treatment are now available, and there's no sense in waiting to see what happens, because we know what's going to happen. It's just a matter of timing, and if you wait and the tumor grows bigger and bigger, you're going to have less option of handling it. So an aggressive approach, wisely applied, is what's important and the way to go. There are some exceptions. Very small, what they call diminutive pancreatic neuroendocrine tumors are now being found with increasing ease because of endoscopic ultrasound techniques, which can see things as small as 2 millimeters or even 1 millimeter. And it doesn't seem sensible to make a big pancreatic surgery to take out tiny little blip like that, especially when we think that they're very slow growing. And this study has shown that actually the risks and mishaps accompanying such surgery are greater than following these very tiny tumors. So at the moment, there is a school of thought for following the little tiny ones closely and not interfering with them if they don't show any movement in their growth. There is one doctor who has loudly proclaimed his ability to extend survival with radical surgery for peanuts, and this just simply lists his figures. And finally, I won't dwell on these. Dealing with hepatic artery catheterization and which choice of agent, whether you want to do bland embolization, chemoembolization, or radioisotope embolization. I favor radioisotopes for a number of reasons, and this just lists them, not the least of which is it doesn't require hospitalization. You don't stay overnight. And this just lists some of the advances in this technique. Now, finally, viewing the online listing of clinical trials going on for neuroendocrine tumors, you can see there's quite an active group of things going on. 1,560 trials are listed for all neuroendocrine tumors, 54 for carcinoid syndrome alone, 109 for carcinoid syndrome. So a great deal of interest is growing in this group, and that's good because it augurs for better treatment, better diagnosis and management in the future. And this is just listing some of the new clinical trials that I arbitrarily think are very interesting, and I've referred to some of them before, and I won't take up more time going into that. And just finally comment, because there's been a lot of questioning about the use of vaccinations and viruses, and there has been an effort exerted in that direction, but it's been very desultory, and part of it wasn't adequately financed, so they've sort of faded away. But there is a group in Sweden that is actively pursuing an adenovirus that seems to have a predilection to be attracted towards carcinoid tumors, and at least in experimental animals has been rather successful, and they're supposedly starting clinical trials in humans, although they've been very secretive about this. But if it comes forth, it will be a big advance. So in conclusion, there are many diagnostic and treatment procedures that are available for neuroendocrine tumors to guide, supplement, and often precede surgery, and also perhaps to circumvent surgery. But I want to point out there is no one standardized treatment for any of these tumors. There's lots of variation, as there is in the tumors. There's lots of disagreement among the experts who follow these tumors. And when we have a specialty meeting, we always argue among ourselves, as you can see. Thank you very much.